Thank you, Keith.
Okay, if you guys could put the slides up.
So Professor Keith is going to give us a talk on mortality benefits with biolimus eluting stents.
Great. Okay, well, everybody's still at coffee, but I'll try and go fast so to catch up some time. So this is an interesting story. I'm going to walk you through a series of clinical studies that have been done with various biolimus eluting stents, which show a mortality benefit, something very unusual with any drug-eluting stent. And of course, I have a very important, relevant disclosure. I am the Chief Medical Officer for Biosensors International for the last 2 years. I'm also still a practicing interventional cardiologist. So if we go back to the original LEADERS study, remember, this is one of the very first large randomized head-to-head all-comers stent trials. This was biodegradable polymer biolimus eluting stent, Biomatrix, against the standard of care at the time, which is the durable polymer sirolimus eluting stent, Cypher. Both of them stainless steel platforms. And these are the 5-year results, also very important. These are not short-term results. These are 5-year results. And you can see here in the forest plot for the STEMI group, there was a very obvious 54% relative risk reduction for the primary endpoint of cardiac death, MI, and TVR. So a clear benefit in the STEMI population. If we look in the AMI population from LEADERS specifically, and this is from HEART in 2015, we can see here that the MACE rate in the STEMI population was halved with a p-value of 0.008, and most of that was driven by a difference in cardiac death. So now we've got an absolute risk reduction in favor of Biomatrix of 8.4%, a 74% relative risk reduction. Now, of course, this study was not powered to show a difference in cardiac mortality, but this is a large effect. If we specifically look at a trial in STEMI, so this is the comfortable AMI trial, this is an all STEMI population, and of course the randomization was biodegradable polymer biolimus eluting stent against the standard of care at the time in STEMI, which was bare metal stents. This was run by Stefan Windecker's group in Bern. And again, we've got 5-year outcomes, so these are not short-term outcomes, 5-year outcomes published in the European Heart Journal 3 years ago. You can see the difference in MACE rates on the left-hand side here in favor of the Biomatrix device, 40.9 against 8.6. That's a 44% relative risk reduction. This time, there's only a very small difference in cardiac death. Most of the difference is driven by target vessel MI and TLR. Now, the difference here, I think, actually, is that, as you can see in this right-hand panel, bare metal stents in STEMI patients are actually safer than Cypher stents. Now, of course, the Cypher stent is of historical interest now, but remember, it was the standard of care for many years. You can see here 11.4% cardiac mortality in the STEMI group in LEADERS against 5.5 in the bare metal stent, and that explains the difference, I think. Now, if we look at the Korean AMI registry, this is a very, very large independent registry. This data was collected independently of any sponsor, where we've got acute myocardial infarction patients, 2,000 treated with a combination of Biomatrix and Nabori, both of them eluting biolimus, 5,000 with everolimus eluting stents, and 2,500 with zotorolimus eluting stents. This is data that you may not have seen. It was only published last year. You can see here on the left-hand side, this is all-cause mortality, adjusted all-cause mortality, and we've got a almost 32% reduction in favor of the biolimus eluting stent against the everolimus eluting stent. And for cardiac death, we've got a more than 40% reduction, again, in favor of the biolimus eluting stent. Now, if we look at the polymer-free device, so polymer-free biolimus eluting stent, as it was studied in LEADERS 3 with a control group of bare metal stent, remember, high bleeding risk patients, but a double-blind RCT, very unusual in head-to-head stent trials, 1 month DAPT in both groups. You'll remember the primary safety endpoint. This was powered for non-inferiority for safety, but it actually showed superiority of the polymer-free device, 29% relative risk reduction in the primary safety endpoint. In the ACS population, and these are not all myocardial infarctions, there's some unstable angina here, this effect was enhanced. So now we've got a 44% relative risk reduction in favor of the biolimus eluting stent against bare metal stent. And finally, we come to Onyx 1, very recent, so randomized controlled trial of the stainless steel polymer-free biolimus eluting stent against a very modern durable polymer zotorolimus eluting stent, Resolute Onyx, sponsored by Medtronic, not by biosensors, high bleeding risk patients, not double-blind, of course, open label, but 1 month DAPT in both groups. 1 year results presented in New England Journal, 2 year results presented very recently in JACC. And you can see here that after 2 years, there was absolutely no difference in cardiac death, MI, or stent thrombosis, the primary safety endpoint. So the stainless steel version of the BioFreedom really held up extremely well. Also, absolutely no difference in target lesion failure, again at 2 years. However, when you do the secondary endpoint analysis, there's a very interesting result for all-cause mortality. This is a 3.5% absolute risk reduction in all-cause mortality in favor of BioFreedom, a 22% relative risk reduction, a number needed to treat only of 29, and a post-hoc power, which is actually quite reasonable for a secondary endpoint of just over 60%. And, you know, this is the hardest possible secondary endpoint. It's all-cause mortality. Actually, there's also a 22% reduction in cardiovascular mortality. Now, it's offset by an increase in TVR in the BioFreedom arm, but this is probably due to strut thickness because, of course, the stainless steel device has thicker struts than the more modern Resolute Onyx. So just in summary, we have in Leaders STEMI a 74% reduction in cardiac mortality in favor of biolimus. In the CAMIR AMI study, we have a 41% reduction in CV mortality, again in favor of biolimus, this time against Xience. In Leaders Free ACS, we have a 44% reduction in the primary endpoint and a 35% non-significant reduction in cardiovascular mortality. And finally, in Onyx 1, we have this interesting and hypothesis-generating 22% reduction in all-cause mortality for BioFreedom against Resolute Onyx. Now, these are all stainless steel stent platforms. It's a mixture of Biomatrix and BioFreedom. This is the scanning electron microscopy picture of the surface of the new cobalt chromium version, the thin strut version, which has been available now in Europe for the last 2 or 3 years. It's a hybrid design with straight and S-links, so it has excellent deliverability and very good apposition, excellent overexpansion capabilities. Both platforms, the polymer-free, the BioFreedom, and the biodegradable polymer version, the Biomatrix Alpha, have been tested in clinical trials, and both of them show improved outcomes against the stainless steel stents. So in conclusion, PCI, as we know, only has a beneficial effect on clinical outcomes in patients with acute chronic coronary syndromes. We know that from many studies. Multiple different studies have now shown mortality benefits with biolimus eluting stents. And of course, they were all with stainless steel platforms. And we think the outcomes will be even better as we move forward with the cobalt chromium platforms. Thank you very much.
Thank you very much, Keith. A fantastic presentation, and we'll have the questions at the end. Now, I would like to invite Dr. Manik Chopra. Dr. Chopra from Ahmedabad will be giving a talk on who is the right patient for TAVR, a beginner's guide.
Morning, everyone, and thanks for the opportunity for presenting this topic before this platform. My topic is who is the right patient for TAVR. So I would divide this in 3 steps. First is confirming the indication of aortic valve replacement, which deals with diagnosis of aortic stenosis, assessing severity of aortic stenosis, etiology, level of obstructions, other valves, PAH, and mainly it is done by transthoracic echocardiogram. Second step is to decide whether it is TAVR versus SAVR. And third question would be assessing the suitability for TAVR and planning the TAVR, that is CT heart TAVR protocol, which would be the gold standard for the same. So confirming the indication for AVR, I would say this is a standard thing. You would look for mean gradient, you would look for aortic valve area, and you would look for ejection fraction and stroke volume index. So it would be either high gradient symptomatic aortic stenosis if the gradient is more than 40. If it is less than 40, AVA is less than 1, ejection fraction less than 50, classic low flow, low gradient aortic stenosis. And if the same findings are with SVI less than 35, then probably paradoxical low flow, low gradient aortic stenosis. What do we do? This we can do a dobutamine stress echo, low dose, to find out whether there is any stroke reserve, contractile reserve or no. If it is more than 20%, it suggests probably there would be some increase in the gradient, and aortic valve area would decrease less than 1. That would be true severe aortic stenosis. If this doesn't happen, then it would be pseudo-severe aortic stenosis. And if there's no contractile reserve, it would be very difficult to assess the severity. Then it would be mainly determined calcium. Second question would be TAVR versus SAVR. And you have reasonable evidence in trials. Because of time problem, I wouldn't go in that. It all started with partner cohort B, A, prohibitive risk trial, core valve high risk trial, partner 2 cohort B trial, cohort A trial with partner 2, core valve intermediate risk, partner 3 trial, and core valve low risk trial. It was a systematic series of trials, unlike the explosion for PCI. And this has led to the recent guidelines of ESC. This was in 2021, and this is this chart. The most important thing of this chart is the cutoff for the age is 75 years. Less than 75 years, mostly the patients with low risk would be offered surgical aortic valve replacement, while more than 75, despite the risk assessment, will be offered TAVI. Patients who have higher risk scores or those who are unsuitable for surgery would definitely be considered for TAVI. Of course, finally, it would also come to patient characteristics now. So depending upon the surgical risk, low surgical risk would go for SAVR, high would go for TAVR. Upon the age, younger would go for SAVR, older would go for TAVR. Previous bypass surgeries for TAVR, severe frailty for TAVR, anatomical features like, if it is not accessible by transfemoral favors SAVR, chest radiation, porcelain aorta, likelihood of patient processes mismatch, chest deformation, annular dimensions, these things will go in favor of TAVR. However, annular dimensions outside available for TAVI valve would go for SAVR. Bicuspids will still be preferred for SAVR. However, we have reasonable experience of TAVR with bicuspids. Thrombus in aorta again for SAVR. And if you are planning any other sort of surgery, would go in favor of SAVR. ESCC AHA guidelines is 2020. It's almost similar, I would say. The most important thing would be cutoff. The cutoff of age is 65 for them. These are again, preferences. I would try to skip them. So finally, who benefits? Almost all the patients with severe symptomatic aortic stenosis, which is tricuspid valve, across all risk categories, especially the elderly ones, and other high-risk patients would benefit. So first was the confirming indication. Second was TAVR versus SAVR, and third is to assess for TAVR whether the patient is really suitable. So there are guidelines for acquisition, available softwares for analysis, and points to be discussed. And multi-slice CT scan, 0.5 millimeter slices, contrast enhanced, ECG gated. For all practical purposes, it means 64 slice CT scan or more. Vascular access, 1 millimeter slices, contrast enhanced, that might not be ECG gated. There are multiple programs, mainly popular as Mac-based Osiris. Or, you have a Trementia program, which is most popular nowadays with PI imaging. However, it comes with a cost. Just to understand, this is how the aortic complex is being analyzed: sinotubular junction, rings, anatomical ventricular-arterial junction, and below that is a virtual ring, which is called as annulus. And points to be assessed on CT scan, whether the phase is systolic, diastolic, whether the valve is tricuspid, bicuspid, and then 10 standard pictures, which would be an aortic annulus, LVOT, sinus of Valsalva, sinotubular junction, LCA height, RCA height, optimal angle of deployment, amount of calcification, aortic arc, and peripheral axis. There are many other things which we would like to calculate, like membranous septum, LVOT calcification, right-left cusp overlay, bicuspid sizing, valve and valve, things, valve at previous mitral position, assessment of chances of coronary occlusion, assessment of alternate access, coronary anatomy, and of course, CT chest and CT abdomen for incidental findings, both in cardiac portion, chest portion, and abdomen. And so this is how these three things would be answered. So finally, if the patient comes, you need to assess the patient, do blood investigations, ECG, X-ray, echo, coronary angiogram if it is not seen in CT scan, and then multi-slice CT scan. Even if the patient is for surgery, it's best to do a CT scan to understand the size of the aortic annulus. Finally, it goes to heart team meeting, and the plan is decided whether it is TAVR or no. If TAVR, then which access, transfemoral or alternate, what type and size of valve, whether it is GA or LA, depending upon your approach. You could use TEE, CVP, and cardiac anesthesia if you are going with initial cases under GA. Later on, it could be a simplified procedure, mainly like a PCI sort of planned procedure, which would take some time from the time you start doing the program. And then you should also plan, anticipate the anticipated challenges and plan bailout strategy. Thank you.
So thank you so much for this very elegant presentation. And we have to move on because we're a little bit late with Professor Chung Woong Koo about the bifurcation PCI with ultra-thin strut dedicated device. Thank you so much, dear Professor.
Thank you. So let's look at the... Thank you for the introduction. Actually, my topic is a very complicated, complex one. The bifurcation PCI with the ultra-thin plus a dedicated device. So I think Dr. Korsandi will discuss about the dedicated bifurcation devices later. So I'll check only the ultra-thin strut plus the result. The bifurcation lesions comprise almost 15 to 20% of all PCI in cath lab. And that is the last challenging lesion along with the CTO lesion because it requires a high procedural successability, but it comes with the low procedural success rate and high complication rate. And also it requires a long procedure time. So the debate on the strategy also come on the bifurcation lesion, 1 versus 2 stents and the pot and kissing balloons. Ultra-thin strut usually says, we define it as the thickness of the strut is less than 70 micrometer. Potential benefits of the ultra-thin strut is it reduces vascular injury, that will accelerate endothelialization and potentially improve clinical outcomes, and also the lower rate of angiographic and clinical restenosis on the bare metastatic area. So and the chronic bifurcation vascularization is feasible only when nanocross technique. So the outcome was just feasible. There's no big difference between the other method. The bifurcation angle and calcification deeply impact on the stent performance, and also the amount of the metal layer into the carina has been suggested to impact on stent restenosis and thrombosis. So it is better to decrease the metal layer and amount of the metal layer. That means the thin strut may lead to the better clinical outcome. And also, I'd like to check the also dedicated bifurcation device briefly. It can facilitate the procedure and increase the success rate. And also, they say there will be less complications. But only a few materials are available in the market. The POX concept is paclitaxel and sirolimus-coated stent, which thickness is 73, almost ultra-thin. And also BIOS expert start with the 140, but BIOS lean C stent has a 70, just to fit to the ultra-thin level. And the Stentis was a 68, and the Triton was a 85, and Access Plus was a 150. So only a few of the dedicated device are actually ultra-thin strut device. So I'm going to check each of the stents. The Stentis was a France-based small company, which is a self-expandable stent. So it is the Stentis was actually the company name. The X position is the stent name. It can be self-exposed. So if you open the side branch with a small balloon, then stent will automatically oppose to the opposite side of the bifurcation. So it'll open the side branch opening very quickly, and there is no need for the larger balloon or the other things to make sure the side branch coverage. So this is one of the results of the multiple bifurcation lesions, including left main, that has a very good result. Only a few trials was presented, including open to trial, and there were only a few single center trials. But they always say they have the highest procedural success rate. So open to trial results says a very good initial result. And there was no big difference between the other trials, but after 1 year follow-up, MACE was about 13%. Considering the bifurcation lesion characteristics, it is acceptable, but not very superior to the conventional devices. But unfortunately, the Stentis company was out of the business in 2019 because of the financial problems. So Stentis stents are not available currently on the market. The BioSlim C stent is a 79 micrometer cobalt chromium alloy, which is mounted on the stepped balloon. So the distal part is just a smaller diameter that can fit the distal to the bifurcation. So if you position the stent at the bifurcation site, you can have this kind of stented deployment. So there was no coverage of the ostium of the side branch ostium, so you can easily access to the side branch. BioSlim C has result of the Polvos 2 trial, and it compared to regular DES. At 12 months, MACE and death, myocardial infarction, and TLL and TVL seemed slightly better, but there was no significant differences. But it makes the procedure simpler, so the operators say that it can shorten the procedure time, and it's very easy to go to the second stented deployment. And Nile concept is similar, but this one has mounted on specialized balloon. The single catheter balloon has a 2 balloon capacity. The main branch catheter plus side branch catheter is assembled together, and there was some small hole for the side branch wiring. So if you put the stent through the double wire, the wire stops here. The stent can be positioned automatically at the bifurcation site. After deployment of the first main stent, you can advance the side branch balloon, and by expanding the balloon, you can open the side branch opening very easily at through a few steps. So now PAX is paclitaxel only on abdominal surface. They have a good initial outcomes. As you see in the main bifurcation lesion, the stent is positioned at the bifurcation. There was just a single mark on the bifurcation level. And after a balloon expansion, you can easily open the LED opening with the dedicated side branch balloon. So nice PACS procedure rate, success rate was very high, almost 100%. Additional stent was applied. Can I see this slide again? Yeah.
One more minute.
Could you give us 1 more minute, please? The slides? Show the slides
Sorry.
and give us 1 more minute.
Actually,
we need another 2 minutes.
Yeah, but actually there was no clinical differences compared to the conventional devices. As you see, the TLL is a little bit higher than the conventional studies because this is bifurcation lesion, and near nicer is sirolimus stent, but it also has a similar result in the latent luminous was about 0.2 to 0.3 millimeter. And in summary, it can facilitate the procedure, so make it the simple procedure for the bifurcation lesion, but excellent the procedure success rate, but there was no definite superior long-term outcome until now. I think that is because there was no good RCT, and a relatively complex and tough lesion of the bifurcation makes it very difficult to get a good result. And the strategic differences between the operators can confound the final result. Thank you for your attention.
Thank you, Dr. Go. Now we'd like to invite Dr. Professor Devinder Singh Chadda. He'll be talking on vessel closure device pre-closure. Dr. Chadda is from Manipal Hospital, Bangalore.
Thank you, Dr. Fazila, for having me here. Over the next 8 minutes, we'll talk about ProGlide, the per-close device. Yes, vascular access is very important. We are increasingly getting used to radial access because that makes the procedure very convenient. But in our part of the continent, you have very small arteries and you need to rely on femoral artery because if you're doing a complex work, you need a bigger sheath, you need to push a lot of hardware, you need guide extension catheters, lots is going to go because we see a lot of calcium. You need to have the femoral access. Now, femoral access is large. It permits the hardware, whatever you decide to put. You can do bifurcation, use the left main PCIs. So it is important to know the femoral access, and it's very important that you manage this access well. Manual compression has been the gold standard, and the problem with the manual compression is that it causes a lot of discomfort, both to the patient as well as the doctor, because the doctor is not sure whether the groin is going to be compressed well or not. There are chances that the patient might have a vasovagal syncope during the procedure, and if the compression has not been done right, you will have bleeding there, and the patient walks out with hematoma. And all he'll remember is the groin when he goes out of the hospital. He'll forget about the good work which you've done in the coronaries, but he'll come back and say that it looks discolored, it's very painful. So there are complications, and we know everything is listed here. There is a certain subset of patients who get more complications, which is primarily elderly, females, those with renal failure, small body surface area, and if you're concomitantly using GP2B3 inhibitors or anticoagulation. We've all seen these complications, and is it some way we can get over it? Yes. You need to do a neat and a good puncture, then only will you get a good closure. So a good closure starts with a good puncture. And we need to remember these anatomical landmarks. You need to puncture the common femoral artery. And it's always nice to know the landmarks. Always try and hit the sweet spot, which happens close to the femoral head. This is a study which clearly showed that in almost 200 patients, which was studied and published in Cardiovascular 2001, that the bifurcation is above the center of the femoral head in only about 5% of patients. So you should try and hit the center of the femoral head. You'll be reasonably sure that you're hitting the common femoral artery. Well, there are different ways of doing it. You can do a Doppler guided, you can use a micropuncture set, or you can do under fluoroscopy, which is probably the easiest. Well, I told you that there are certain shortcomings of manual compression. Can we overcome that? We have a lot of vascular closure devices available, and if you use these vascular closure devices, you'll be able to close the puncture site well and make the patient free of complications. So today we'll see different devices, but my primary focus is going to be on ProGlide. You have certain devices which work passively. You have hemostatic plugs, you have compression columns which are available. There used to be one which was marketed earlier by erstwhile St. Jude called FemoStop. I'm not sure whether it's available or not. You have certain active devices which can be collagen-based. That means you have a clip which goes inside and you deposit the collagen on top of the puncture site. You have suture-based devices, clip-based like StarClose, and suture-based devices like ProGlide or ProStar. From here on, I'll talk a little about the ProGlide. This is a suture-based device, and as is shown on the slide, it's got the device as well as the suture trimmer. The basic device has certain landmarks, which you have a marker lumen. That means it tells you whether you are within the lumen or not. It's very important. So there'll be a gush of blood which will come out of the marker lumen, and it is the body which houses the needles as well as the sutures. So let's have a closer look. There's a lever at the bottom, so that when there are steps which are written, so it's just not possible to run through all the steps in 8 minutes. So I'm just sensitizing you. The device has to be in the lumen of the vessel, and thereafter it has to be retained within the vessel by the foot plate. And once you have struck the vessel wall and you're retained against the vessel wall, you have to deliver the suture inside. The sutures are delivered by the plunger, and then you can bring it out and cut the suture with the quick cut device which is there on the body of the ProGlide. And once you've deployed the suture well, then you use this device to cut the suture close to the vessel wall. So this is the suture trimmer, and this goes closer to the vessel wall, and not only it delivers the knot, it also cuts it. So the device can be used for a 6 French, or if you use 2 devices, you can close up to about 21 French sheath. The steps involved are you need to position, you need to deploy the needles, you need to capture the suture, you remove the needles, you advance the knot onto the surface. Each and every step is very important, and then you finally trim the device. So the first step, foot plate deployment. Once you've deployed the foot plate, then you press on and deliver the needles. Once you deliver the needles, the sutures are across the blood vessel, and thereafter you have a pre-night suture which is delivered onto the surface, and finally you remove. And if you see inside, there are 2 needles. One is an anterior needle and a posterior needle. And what you do by delivering these needles is that the posterior needle is a little longer. It delivers the suture. If you see, this is about green and white in color. Actually, it's blue and white. And once you pull this out, the suture is right across and the knot is right on top. You have to deliver the knot onto the surface of the blood vessel by releasing the foot plate and taking the device out. Once you've done that, you have a loop with the suture which is formed over the surface of the blood vessel. All you need to do is that use the suture trimmer, deliver the knot onto the surface, pull the white thread, it tightens the knot onto the surface of the blood vessel, and that ensures that you've achieved hemostasis. Well, that's the 4th step. So foot plate deployment, you deploy the needles, deliver the suture, and then you cut the suture using the suture trimmer. Well, what are the precautions? The most important step, the first step is that you need to do an angiogram and see whether you punctured correctly or not. You have to be in the CFA, not in the superficial femoral or the profunda. The vessel size has to be more than 5.5 centimeters in diameter, because if the vessel is smaller, or if there is a calcium speck or there is a plaque volume there, you should avoid using the ProGlide. If there is hematoma or bleeding which has happened during the procedure, it's best avoided, because the vessel wall is now coated with an organized thrombus. So you might not be able to deliver the suture onto the surface of the vessel. And if you're not able to do that, the device will not deploy properly and you'll have problems. Especially in patients with morbid obesity, the gap between the skin and the vessel wall is slightly larger, so that can cause problems. This was one retrospective analysis which we had done at our center. About 1,750 ProGlides were deployed, and we compared with the manual compression. What we noticed was that the ProGlide was safe, effective, and was associated with very few complications. Obesity, hypertension turned out to be the markers for increased bleeding in both the groups. So it's a pretty safe device with a very short bed rest what the patient requires, and most importantly, you can re-access the vessel. Well, there is a learning curve and there is a device cost. You have to be mindful of that. And if you have The other downside is that you can have small hematomas which can form in groin infections. To conclude, I would say that you need vascular closure devices for an efficacious closure of your groin punctures. There is, in ProGlide, you have a natural suture-based device which works amazingly well. It has a learning curve, and if you have resources, you must use it for your femoral access. Thank you.
Thank you so much, sir. So we move on to our next speaker, Dr. Chunmuga Sandaram, about the future is here, when to choose a leadless pacemaker. Thank you so much for your attendance, sir.
So, first of all, pardon me for the change in topic. I think I will be surprised to to see the topic here. Since I have a flight to catch, I'll ask whether I can present the next session topic here. So I'm not going to talk about the leadless here. I'm going to talk about yet another newer modality of pacing, which is conduction system pacing. So we know that right ventricular pacing is going to produce chronic pacing-related complications, dysynchronous activation, LV dilatation, LV dysfunction, heart failure, arrhythmias, which is ultimately going to increase the morbidity and mortality of the patient. So that's how the conduction system pacing has grown up. So it was suggested as an alternative to overcome the limitations of RV pacing. Now recently we have adapted this as one of a beautiful strategy as an alternative modality for doing a resynchronization therapy in patients with cardiomyopathy. So this strategy is being increasingly adopted in the last couple of decades. So we should know what exactly is conduction system pacing and how to run an effective conduction system pacing program, at least for a country like India and Bangladesh, where the cost is going to matter a lot. If you're going to learn these techniques, this is going to give an effective, cost-effective resynchronization therapy for patients with a heart failure. So choosing the right patient, choosing the right tool, choosing a simple technique, and choosing a simple algorithm for capture confirmation, and finally choosing a strategy for following up. These are the topics which I'm going to discuss in the next 8 minutes. Choosing the right patient. So can all pacemaker implantation be a conduction system pacing implant? This is rather a difficult question to answer as of now, but at least in patients who need a committed ventricular pacing. For example, a young patient with a complete heart block who requires pacing for the rest of the life, and for those patients who needs a cardiac resynchronization therapy, whether it is an ischemic cardiomyopathy or a non-ischemic cardiomyopathy with the white QRS, especially with a prolonged HV interval. And for those patients who develop pacing-induced cardiomyopathy, the pacing-induced cardiomyopathy, we know the incidence is going to be 5 to 10%. So in those patients, instead of going for a CRT, at least you can target these patients for a conduction system pacing, which is going to improve their LV ejection fraction. Of course, the challenging thing is AVJ ablation. So these are the patients for whom AFib was deemed as a permanent one, where you cannot give solution for the AFib. We can give a solution for the fast ventricular rate by doing an AVJ ablation. Previously, this was not a much talked strategy because we were doing RV pacing. We were creating one disease for treating one disease. But with the advent of conduction system pacing, more and more patients with a permanent atrial fibrillation and fast ventricular rate are undergoing AVJ ablation to control their ventricular rate. Choosing the right tool. So previously we had only one industry partner offering this sheath and tools. Now we have all the industry partners providing both the sheaths and the leads. So delivery catheters from Medtronic, we have C315 and C304. In Biotronic, we have Selectra. Abbott, we have Agilis Hispro. And from the Boston Center, we have SSPC family of catheters. As far as the lead is concerned, there is only one lumenless lead which is available, which is nothing but the 3830 Select Secure lead, and all other leads are conventional style-driven leads. Choosing a simple technique. So we need to know some fluoroscopic anatomy for performing conduction system pacing. We do not have to have a EP lab. We just have to know about the radiological anatomy of cardiac conduction system. Go to RAO view, keep two catheters, one in the his bundle region, another one in the RV apex. This is how the cardiac conduction system will look like. Your his bundle catheter will correspond to the distal his signal, and you have to draw an imaginary line connecting the distal his to the RV apex. As you can see here in the picture, the initial 1.5 centimeter is the target zone for entering into the left bundle. For doing a his bundle pacing, you have to deploy the lead in the his bundle zone, and for doing a left bundle pacing, you have to deploy the lead in the initial 1.5 centimeter. Of course, if you have an EP lab, you can connect the patient to the EP lab. If you don't have an EP lab, you can use a simple 12 lead ECG or even a TMT monitor to monitor the pace QRS morphology. The idea is to deploy the lead from the right side of the septum into the LV subendocardium. Remember, we are still working on the right side of the heart. So we have to start from the RV aspect of the intraventricular septum, drill the lead slowly, monitor the pace QRS morphology. So you have to start from the right side, pace in the initial 1.5 centimeter below the his bundle, see the pace QRS morphology on the right side of the septum. It should be a W pattern with a discordant QRS complexes in AVR and ABL. That will be the right spot. Then start deploying the leads. Give rotations gradually, and you can see in lead V1 there is a notch which gradually ascends up to form an R wave. So once an R wave is formed, so that indicates that we have reached the left bundle area. You should not give further rotation. So instead of giving turn by turns, we have modified the technique as a rapid rotation technique, what we call it as a PVC guided approach, where instead of giving simple turn by turn rotations, we usually give a rapid rotation. And this rapid rotation will generate premature ventricular complexes, as you can see in this picture. This premature ventricular complex morphology changes as the lead traverses from the right side to the left side of the septum. So once the morphology of PVC change from QS to QR pattern, you can see here there is a good QR pattern in lead V1. So once this is reached, that means that you have reached the target site. You don't have to give further rotation. You can stop there and you can confirm the capture of left bundle. So these PVCs with the QR pattern, we label it as a template beat. So to put it in a simple term, start from the right side of the septum, give rapid rotations, generate PVCs. So once the PVC of RBBB conduction delay is achieved, then that is the right spot, which we call it as a template beat. Of course, there is a chance that your lead may still further travel into the LV cavity. So that is one potential danger of performing this deep septal pacing or so-called left bundle branch pacing. Your lead might go just into the LV to produce septal perforation. That is quite common here. Usual reported incidence in the Chinese article is 2%, but our incidence is quite high. We have almost 14% incidence of septal perforation. So this is a part and parcel of the technique. So all you have to do is identify the septal perforation on table and correct it so that you can avoid future complication. How to identify it? There are three important ways. One is pacing impedance. It's essential to monitor the unipolar pacing impedance because the unipolar pacing impedance will tell you what is happening at the lead tip. So you want to know what is happening at the lead tip. If the unipolar pacing impedance is less than 450 ohms, don't accept, your lead is perforated. And look for the current of injury. In any conventional pacing, if you're doing a septal pacing with a conventional styler-driven leads, you always look for a current of injury in the program system analyzer. Similarly, here you have to look for a current of injury, and there should be a good ST segment elevation, just like an anterior wall MI. There should be a good ST segment elevation. Only if it is there, you have to accept. Otherwise, you have to take it as a septal perforation. You have to take the lead back and put it at an entirely new site. So this is a very benign complications. If you are identifying it on table, pulling the lead back and putting it at a new site is going to avoid a future thromboembolic complication. Of course, choosing the algorithm for capture confirmation, a lot of criteria are available. I'm not going to confuse you. So I would say simply, there should be one major criteria, just like a rheumatic fever, a QR in lead V1, along with demonstration of left bundle potential. You know that left bundle is going to generate potential, or measure R wave peak time at lead V5 and V6. So in lead V5 or V6, if your R wave peak time at high output and low output, 8 volt and 2 volt, if it is constant, that means that you have captured the left bundle. I'll just show this R wave peak time. I've measured it at 8 volt and 2 volt. You have to measure from the pacing artifact to the peak of R wave. It should be constant. Like in this case, it is constant at 56 milliseconds. That confirms that you are in the left bundle area. Choosing the right strategy for follow-up, we do have loss of conduction system captured during follow-up. So you always have to track the patient, especially if it is done as an alternative modality for CRT. Look for capture confirmation. Look for echocardiographic LV function assessment. Look for the lead depth inside the septum, and always look for the pacing parameters. See whether any impedance has changed or if you have any change in the capture threshold. So remember, this is a very novel pacing modality. So this is evolving. At least in the last 5 years, we have at least 100 articles published in the span of 6 months. Every 6 months, you can see at least 100 new articles getting published in this modality. This is one thing which is giving a good hope for poor patients who cannot afford a cardiac resynchronization therapy. So if you are going to use this, this is going to give a cost-effective resynchronization therapy. Thank you very much for your patience.
Thank you so much, sir. Thank you so much. So our final speaker unfortunately couldn't make it and couldn't attend, so we will have to close the session. We're 10 minutes late, but we could ask the
maybe
door
we
for
could
a few
have
questions.
some questions. Do we
Some
have a prize
questions
for
to
the
the
best?
speakers.
Best. We will, for this session we don't. So I would. So our discussants could maybe make some final comments. We're already 10 minutes late. Not too bad. So maybe everyone could say a few words about this session.
Yeah, I think a fantastic presentation by all our speakers, starting with Keith, who talked about biolimus eluting stents. And even though the data shows that there is an improvement in survival, the reason is not very clear. So we need to understand much better. Probably we need to have, of course, Cypher is not there. We're not going to use bare metal stents anymore. So those two first trials are probably not really real world right now. But the study that Onyx won, which is sponsored by Medtronic, and compared to the primary endpoint is negative, but the secondary endpoint showed that there is a difference in mortality in favor of biolimus eluting stents. And so we have to understand why is that. And so that's a fantastic case. And we need to have probably much more randomized trials. The next speaker, I think we had a great presentation of, I think, the dedicated bifurcation stents by Dr. Go. Very nice. He covered actually both talks. Thank you. The last speaker was not there. He was supposed to talk on drug-eluting dedicated bifurcation stents. But I think this is an era where we still are understanding, trying to make Triton drug-eluting stents in the United States. We'll have more data on that in the future. And pacing, I think, is really important. We know right bundle branch pacing is not valuable anymore. It can cause LV dysfunction. I think, thank you, Dr. Ponusamy, talking about his bundle pacing and the septum, which your technique is really very good. And thank you very much. And any other?
So I would like to thank all the speakers. And actually, your presentation was amazing about the dedicated bifurcational stents and all the drawbacks of the bifurcational techniques. I believe we need more data about the dedicated devices because usually the thin part connecting the two stents is still not that strong. The incidence of restenosis, keeping in mind that we, at the end of the day, we should cover the carina and do reconstruction, so more data are needed. And our speaker about the closure devices, we thank you so much for your talk. I believe that in every cath lab, at least every fellow or every cardiologist should adopt the technique of using a closure device. Sometimes it's mandatory to avoid the complications and the major bleeding that could occur, especially after TAVR. Our dear speaker, Dr. Manek, thank you so much for your talk about selecting the patients for TAVR. It was very elite, very simple to let us know which to choose, who to choose to go for TAVR versus SAVR. Thank you so much. I would like to ask the audience if they have any questions for the speakers.
I just ask our discussants to make any final comments. So Professor Maksumul Haq, any final comments from your side?
Thank you all the speakers for the nice presentation. My idea is that unless a stent comes up with a robust data regarding bifurcation or any other thing, it's very difficult to establish nowadays because we are comfortable with all the bifurcation techniques. And regarding per closure, because we are doing mostly radial, I think in Bangladesh will come up when we start doing TAVR.
That's the point. This session was more like new things for in the context of Bangladesh. So we don't do TAVR. So about basics of TAVR. So we need the device to close the vessels. So
we should start practicing some of the devices.
Yeah, absolutely.
And regarding the pacemaker, I think it was an excellent lecture. Very difficult for interventional cardiologists. I think this is the domain of EP people. Right. And that's all. Thank you very much.
Thank you. So, Dr. Khalikuzaman, just very briefly, not all the cases, whatever you felt was relevant or important.
Thank you. Thank you, madam. Congratulations all the presenters for their brilliant presentation. The thinness, I want to comment on the thinness of the start, because the outcome of the any procedure does not depend not only on the thinness of the stent, it depends on the drugs itself, drug vehicle, as well as thinness also. But thinness does not always give good results in lesion, osteal lesion, calcified lesion, tight lesion, and the fibrotic lesion. So does it always, will it always provide benefit to the patient, the ultra thin stents? And third is the bioluminescence eluting stent. That was once upon a time, it was very available in our country in the form of Nobody, but subsequently don't get it anywhere.
It's available.
And now it is available now. Okay, fine.
It was always available as biometrics flex, then
Right.
biometrics
Biometrics as well. Biometrics.
access stent as well. It's always been
But the
available.
start composition is on stainless steel. Stainless steel.
Nobody also had
So what he was commenting that explanation of the good benefit of this stent is not yet very satisfactory as well.
No, it's a very well established stent actually.
But madam, the drug vehicle, the polymers, even with biodegradable polymers, the outcome of these biodegradable polymers or absence of the polymer stents does not provide any superiority. Rather, all the studies shows non-inferior to the vehicles. So with this bioluminescence stent, only sirolimus derivatives, the bioluminescence is sirolimus derivative drug, and the stainless steel stent composition, does it explain all the things of very beneficial over the producing mortality benefit to the patient? That is questionable, I think. Thank you, madam.
Well, actually, I use biometrics a lot. I mean, here we are not here to propagate any, but it's a very safe stent and
Yes.
it's very user friendly. And final comments from you, sir.
Thank you very much. All the speakers speaks very clearly to their contents, and this is something new in Bangladesh that we have observed through their lectures. I am giving a special thanks to all the speakers for their innovative procedures. Thank you, ma'am.
So we can conclude the session. Thank you.
Thank you.
Thank
As
you.
we are running short of time, so we are going to moving to our next session, that's on echocardiography. And to chair this session, I would like to request Dr. Satish Kumar Parashar and Professor Fazlur Rahman. I would like to request Dr. M.A. Mazid Khan to be present over the dais as a discussant. And to conduct this session, I'm requesting Dr. Noor Nahar Mahua. Requesting all the speakers of this session and also as well as the chairperson, please come to the photo booth and hand over the memento to our speakers.